about just benign gynecologic health issues, which is mainly what I deal with. Robotic surgery also is hugely used in gynecologic cancer surgery. So we'll touch on that and talk about more about. I've got a list of all the procedures that it's used for, and then I've got a little clip so you can kind of see the beginnings of an actual procedure and why I like it so much. When we talk about gynecologic surgery, the three main reasons we do surgery, there's others, but the three main reasons are uterine fibroids, endometriosis, and pelvic organ prolapse. And we see pelvic pain, we see abnormal bleeding, we see a lot of symptoms, but these are the three main diagnoses that we usually come up with. And very oftentimes they're associated with urologic problems like losing urine when you cough or sneeze, or just general incontinence. This is fibroids. It's what they look like. They can be on the inside of the uterus, on the outside of the uterus. They can be hanging off pedicles. Women can have fibroids and have no symptoms. They can be quite small. They can be huge. They can be massive in size. And they tend to, most of the time, grow slowly over time. And the most common symptoms that they cause are bleeding and pain. And uterine fibroids are the most common reason in the United States that we have hysterectomies. It's the most common reason to do a hysterectomy in the United States. We don't know what causes them, but they're very common. 25% of all women in the United States. So that's a lot of women that have fibroids. They're generally, they can run in families, and they tend to be more common in black women, more common the older in the 40 to 50 age. And I'm not really sure about what eating habits cause fibroids. That was a new one, and I haven't had time to look that up, so I don't know about that. They tend to be more common in women who are overweight, but certainly not only in that patient group. Heavy bleeding, any kind of pain really, lower back pain, abdominal pain, pain with intercourse. Because the fibroids are heavy, they're made of muscle, and they enlarge the uterus, and it sits on your bladder. Then you can use. A lot of women will say, "I have to go to the bathroom every 5 minutes," and just because they never can really fill their bladder up, so they have to empty their bladder more frequently. They can cause infertility. Of course, I'm a gynecologist, so that's why I see these patients. But they can go to see their primary care physician. We generally do ultrasounds. We don't really do CT scans or X-rays. Hysteroscopy is when you put a little scope inside the uterus and look, and sometimes if we have bleeding in a younger woman, or if we have someone who we want to preserve fertility, we'll do a hysteroscopic surgery on the patient. But ultimately, we try to control the symptoms with medications like birth control pills, Depo-Provera shots, hormonal therapy. That's a problem if there's a contraindication to birth control pills in the patient. If they've taken them and they've had side effects, or if they've had blood clots, or they're hypertensive or diabetic, or can't take birth control pills, then we lose our ability to treat these with medication. And so the most common surgery we do for fibroids is hysterectomy. If there is a very small fibroid on the inside of the uterus, sometimes we'll do a little procedure called an ablation where we burn the lining of the uterus, but the failure rate with that is pretty high. And I don't know anybody that's doing fibroid embolization. They're probably doing it somewhere in Houston, but the numbers on that really are not really good. And what they do with that is they throw the little catheter up into the uterine artery, and they essentially will try to cut off the blood supply to the uterus. There is quite a bit of pain after that procedure, and it just doesn't work very well. So it's kind of fallen out of vogue. If a woman wants to preserve her fertility and her uterus is not massive up to her belly button or higher, then sometimes we'll go in and just take the fibroids out, and we can do that robotically also. And then hysterectomy is the ultimate therapy. We just have to remove the uterus. There's also a medication called Lupron, which is an injection that puts you into a temporary menopause, but when you stop the injection, the fibroids start to grow again. So we generally preserve that for women who want to have children in the future. just to try to buy them some time to get their uterus smaller and to increase their chances to hold a pregnancy. You can't really see the top of this slide, but it compares different treatments for fibroids. The endometrial ablation is a really great procedure. It's an outpatient procedure. It just doesn't work really well for fibroids. The traditional abdominal hysterectomy, where you make an incision either kind of in your bikini line or up and down, is a 6-week recovery time. There is a significantly higher risk of complications because you make the big incision. There's more blood loss. It requires about a 3-day hospital stay at least, and like I said, the recovery time is 6 weeks. If you do a laparoscopic robotic surgery, then you make 4 small incisions on your abdomen. You make one right above your belly button. Depending on how big the uterus is, you make one above your belly button, about the width of my thumbnail, less than an inch. One to the left of that, and then about the same size, and then 2 kind of one on each side of your abdomen, about the width of my little finger. And that's it. 4 small incisions, and we do the surgery through using the robot laparoscopically. We remove the uterus and sometimes tubes and ovaries vaginally, and then sew the top of the vagina up again using the robot. And it works quite nicely. It can be a little challenging because fibroids can grow to be really big, and so it can be challenging on the bigger uteruses, but most of the time we catch these when they're below the belly button, and those are the perfect candidates for laparoscopic surgery for fibroids. In the old days, we would have to make an incision on every one of those patients. You could not do that vaginally. Okay, I don't know what that slide is. Endometriosis, that's what that slide is. I got it backwards. This is more and more a problem that we're dealing with using the robot. And endometriosis is where the tissue that normally lines the inside of the uterus grows outside the uterus. And it looks like the second slide. You see these dark areas, and you see scar tissue forming. Everything sticks together. And the main symptoms are pain and bleeding, and it can cause infertility. So we tend to try to be pretty aggressive about treating endometriosis. The robot is ideal for this because with the traditional laparoscopic approach, you can only move your instruments in just very limited directions. And with the robot, you've got 360 degrees of turn with your instruments. And so you can actually excise the endometriosis. You can burn it off if it's shallow, but if it really needs to be excised, you have instruments that are just the same as if you were you had the patient open, that you can actually remove the endometriosis. And so it's a great method of therapy for endometriosis. And again, this slide is just to say, open surgery, higher complication rate, longer recovery, hospital stays longer, expense is longer, and the laparoscopic approach, especially with the robotic approach, is just a much, much, much better treatment for this. Pain level, much less postoperative pain, much lower complication rate, almost no blood loss. These patients we do as an outpatient. They don't even stay in the hospital, and they're back to their normal activities within a few days. This is a uterine prolapse, and this is classically something that we have done vaginal surgery for. And there's if the uterus, you see how the uterus is up in the pelvis above the bladder, and how it falls down then into the vagina. If it falls all the way out of the vagina, then that's still something that most of the time we fix vaginally. But these varying degrees, when it's not that far, that can still be very uncomfortable. And the problem with the vaginal surgery is it's a blind approach. You go up vaginally and you can't see in the pelvis. And so if you have your bowel stuck to the top of the uterus, you're more likely to have a surgical complication because you can't see it. And so laparoscopic and especially robotic surgery is becoming more and more in vogue because we can see from the top down. So you get the benefit of the vaginal surgery and the abdominal surgery without prolonging your recovery time. and without increasing your complication rate. There is a procedure where once you've had a hysterectomy, your vagina falls all the way out, and the urologists do the procedure here where you tack it's called a sacral colpopexy, where you tack the vagina back up using a mesh to the pelvis, and that's done quite well robotically also. And that's the sacral colpopexy that we do in the hysterectomy. Cancers are really where robotic surgery first was explored, and it's just really revolutionized cancer surgery. In the past, for gynecologic cancers, you had to make a vertical incision, often above the belly button, and because you take not only the uterus for these surgeries, but you take the ovaries, the tubes, the upper third of the vagina, and you have to do take pelvic lymph nodes out. And so to do that, the only way to do it was to make an incision. Now, because of the robotic technique, we can do these dissections laparoscopically. And so we have our full staging, and at the same time we're treating the cancer, and yet we're able to get these patients up and going quicker, and we're able to start any future therapy that they need faster because it's a quicker healing time. So it's just really been a huge, huge thing as far as gynecologic cancers go. And I'm just going to kind of buzz through that. This is what the robot looks like. The console at the top left is where the surgeon actually sits, and we look through the viewer there, and we actually I'll show you a clip of actually what we see when we're performing the surgery. Before we sit down to the consult, we're at the patient's bedside. I wish I had a laser pointer.
It's on there. It's red. The red dot.
This is there are a patient underneath here. This is what hooks up to our 4 incisions. We have these 4 arms. Generally for gynecologic surgery, we just have to use 3 arms, and then we have an assistant who's standing at the table with a suction apparatus or that can grasp and hold things so we can see. And the assistant can see up on this TV screen what's going on inside the abdomen. But we're actually sitting looking through this little viewer, and we get a 3D picture of what's going on in the abdomen. And with our fingers then, we are moving these instruments up here. And we have different instruments. We have instruments that burn, we have instruments that grasp, we have needle drivers that we can sew with, but it moves actually even better than your hands because it can move 360 degrees. And then we have the camera is a special laparoscopic camera that allows us to have a 3D view in the pelvis. So the first thing we do when we start a case is we put the patient in position. For a vaginal surgery, we'll have her up in stirrups, and I'll insert we call it a uterine manipulator inside the uterus and tie it in place so that I have an assistant that will move the uterus back and forth so I can see on either side. And then we'll insert the trocars, and then we'll drive this part of the robot up next to the patient, and we'll pull these arms over and attach them to the trocars, which are the little plastic instruments that go into our abdomen. And then we will attach those little clips. They just kind of clip on to that. And then we have the different instrument arms that we attach in the different arms. And once I get that done, I'll leave my assistant right at the table, and I'll go sit down. They'll insert the laparoscope into this upper arm, and I'll sit down and look to make sure that I can see in the pelvis and get my focus. And then they'll insert, as I'm looking, they'll insert the instrument arms in, and they'll give me control of the instrument arms, and then I will start my surgery. And do all my surgery while sitting at the console. I like it because I get to sit down. And at the end, then when we're finished, we'll get up, we'll undock, we call it docking and undocking, and pull this away from the table, and then we'll remove the trocars. I will remove those the trocars that are in the incision close the incision with a little suture and glue, and we're done. There is a little learning curve. I've done over 300 of these now, and so a typical easy hysterectomy I can do in about 45 minutes, which absolutely mimics what I could do with an open case, maybe even a little bit faster. So, once you kind of get the technique down, the surgery itself is the same. It's just different instrumentation. So it's not a different, really, procedure. It's just a different way to do a hysterectomy. And once you get the technique down, it's just really slick. And what has amazed me is I can do a hysterectomy. Before we did these, we were doing just laparoscopic hysterectomies using our instruments through just the trocars. And it makes absolutely no sense to me, but my patients that I do robotically have less pain post-operatively, and they just, across the board, recover more quickly. It makes absolutely no sense to me because it's still just the 4 incisions. I don't know why that is, but it is, and it's just amazing. And I've talked to other surgeons, and they see the same thing. These are all the surgeries that are now being done using the robot, so it's not something that's just gynecologic. The urologists are really doing a lot of prostates with especially the radical prostatectomies, a lot of them with the robot now. Of course, I've talked about mine. General surgeons are starting to get on board. We haven't got any of our general surgeons here, but it's just a matter of time. The heart surgeons are doing it, and it's starting to be really big in throat and thyroid cancer surgery. So I think we're just seeing the tip of the iceberg as far as what's going to be done. And of course, they're always updating the equipment. They're looking at smaller laparoscopes. They're looking at flexible instruments now that you can actually move not just the end, but the whole instrument. And when that technology becomes available, it's really gonna take off. It's gonna be easier to learn. This shows the 4 incisions. This is the typical fan and steel incision, and this is just our 4 small incisions that we have for the hysterectomy. And then this is just as opposed to the up and down incision. If it's a bigger uterus, sometimes you have to make an extra incision. If it's a uterus that's above the belly button, I mean, that's a huge uterus. And so sometimes you have to make an extra incision to really give you some more traction so you can pull the uterus from side to side so you can see. But that's still just 5 small incisions rather than that big up and down incision in the old days we'd have to do. These are just test stories, but I'm going to show you the clip because I think that's really, will let you see kind of what So basically, this is what I see when I look in to do a hysterectomy. And you can imagine if I was doing an open case, I'd have to have my head all the way practically in the abdomen to see that well. But I'm giving a magnified view. I can move in, I can move out. I can even go up microscopically if I want to. Get this to go back and play again. Okay. I'm sorry, I'm not technologically.
The square.
There you go. So I'm going to stop it just right there so it doesn't play through. So this is the beginning of a hysterectomy. We're actually leaving the tube and the ovary, and that's the uterus. This is an operating scissors that you can use either with cautery or just plain as a scissor. And this is a grasper that also has a bipolar cautery. And so we go in and, this is just, you can see the vessels. If we look down here, we can see the ureter. So we can see our anatomy up close. which is huge. It helps you avoid any complications involving those structures. And we burn across there, and then we cut, and then we burn across this ligament, and we cut, and we do that all the way down the uterus. But you can see how good that visualization is. There's just, even if I was doing an open case, I could not see those structures that closely. So it's just, surgically, it's just a great way, and that's why your complication rate is lower, really, with the surgery, because you can see so much better. And I think there's just something about not actually just the minimal. I mean, even though we move the organs around, it's just not the same as making a big incision and pushing on everything as much. And I think that just has to be a big explanation of why we have so much less postoperative pain. The patients will stay in the hospital overnight. Although I've had one patient I've sent home the same day. I've had a bunch that probably could have gone home the same day. Mayo Clinic is sending all of theirs home the same day. And I'm just not really I just can't really do that yet. But I have patients that probably would have done really well. They are eating the same day, they're up and active the same day, and they are taking oral pain medicine the same day. And it's just a much quicker recovery time. So I've had one really motivated patient I sent home the same day. I'm worried about her, but she did great. The healing time, the one thing that we do see is the healing of the vaginal healing time is a little bit higher with this. With the traditional hysterectomy, we tell patients not to be sexually active for 6 weeks, and this one we kind of go to 8 weeks. There's just something about this technique that sometimes you heal a little bit slower in the vaginal area. Nobody's really been able to explain that, and they're really looking at that right now. But we haven't had a big problem with that as long as we're careful. So that's it. Do you have any questions about robotic surgery or hysterectomy or any of the above?